Well, baby, you've been on my mind. I think about you all the time. Oh, I wanna see your face. That don't make me wait.
I haven't had toothpaste for a couple of days. Been dry brushing.
Said the dentist.
Yeah.
Is that like dry humping?
So I was at the office yesterday and I was like, I need to get some toothpaste. So I went and found some of the sample toothpaste.
There's not a CVS near you.
There is, but that requires going somewhere else.
Oh, got it.
And I was already at the office.
Oh, okay, that works. That works.
I thought, and then I got home and I couldn't find any of the samples. So I guess I left them on my desk or something like that. Anyways, welcome back, everybody. Sleeping Around the Podcast. Dr. Brandon Hedgecock here with Dr. Ann Morris.
Yeah, we're missing our third appendage.
Our extra leg we're missing.
Yes.
Yeah.
Our bionic
the
human
awkward
person.
one,
Yeah,
the awkward
exactly.
one.
Yeah.
Yeah,
Aw,
yeah, it's
Matthew.
okay. We're going to figure this out without him.
Yes,
It
we're
might
going to
be
navigate it.
It might be a little weird
Yeah.
without having him here. It might be better. We don't know.
Yeah. We might actually just exclude him from now on.
It
It's
might-
just going to be like,
if-
listen.
Yeah, not even worth it. So, Ann, how long have you been in the sleep world?
Are you trying to get at my age?
Well, indirectly.
You never ask women. I'm going to be 40 this year.
Indirectly. Are you
I'm
really?
going to be 40 this
That's
year.
awesome.
Yeah. But I've been in
Welcome
sleep
to the club.
medicine. It's not a club that. No, actually, I'm fully prepared for it. I'm like,
Embrace it.
let's do it.
Embrace
let's do
it.
it. Yeah.
Yeah.
I actually have taken the Benjamin Button medicine so that this way I age
The
backwards. Yeah, exactly.
backwards, yep.
But I've been in sleep medicine now, approaching 7 to 8 years.
Okay.
So I finished medical school, then did my pediatrics and pediatric neurology training, then sleep medicine training, and now I've been in clinical practice as an attending for about 7 years.
It's always amazing to me how long you have to go through, like
Yeah,
all
it's
the
horrible.
steps in medicine that you have to take
Yeah.
in between fellowships and residencies and this and that.
Yeah.
Before you're finally
For
like,
some reason in dentistry, they just like turn you out and you're like
Yeah.
free to drill in anyone's teeth.
well, I mean,
Just kidding.
yeah. It's always surprising. It's just been it's always amazing to see our colleagues and how long, and like the oral surgeons too. Some
Yeah.
of them, they're 6 years after dental school, and then
Yes.
and then maybe some of them do like a plastics fellowship
Yes.
or something like that.
Yes.
And it
Yes.
seems like forever. So like, do you feel like you're barely starting your career then?
Oh, I definitely feel like I'm early to mid career, and it's interesting because based on like chronologic, many would consider me as early career, but based on my CV, I'd be considered like mid to late career. And so I've been just very fortunate of being able to just be surrounded by a lot of people who are completely committed to change in sleep medicine, like really trying to do something transformational. And so that has resulted in the ability to, number one, grow professionally in advancing my career in leadership, but then also be able to be a part of some really amazingly impactful research where we're trying to contribute to all areas of sleep medicine. So I've been able to do some obstructive sleep apnea research, narcolepsy, idiopathic hypersomnia, and even in pediatric research of looking at just how sleep evolves over time. So that has been amazing.
So it's interesting to see the combination of pediatric neurology and sleep. What was the driver to get into sleep for you?
Sure. So, although everyone thinks that sleep tends to be like a pulmonary focus, the reality is sleep is a neurologic process. So
Okay.
when I was in my training for child neurology and adult neurology, one of the resounding things I kept seeing was like, everyone has sleep problems, right? It wasn't, for me, at the end of the day, it wasn't like, oh, they have epilepsy and they also have a sleep problem, or they have multiple sclerosis and they also have a sleep problem, or they have Parkinson's and they also have a sleep problem, or they have stroke and it was like, this is a neurologic problem, and this sleep problem seems to be very much part and parcel of what their neurologic issue was. And for me, the reason I initially was drawn into sleep was because of the fact that I viewed it as an opportunity to actually provide better neurology care.
Okay.
So I viewed it as like, it's not I'm studying this second comorbidity. I'm studying what I can utilize as a tool to change the trajectories for patients, or also be able to better identify when there may be a neurologic problem.
Yeah. Now, we've talked a little bit about this, and I know it's really easy to get off tangent when we start talking about the problems with the healthcare system or
There's a problem with the healthcare system.
man, I should rephrase that. Maybe the issues that we see with healthcare system and how it's and it's a very convoluted thing that's hard to describe. But you mentioned something just a minute ago in terms of impacting change in
Yes.
how we view sleep medicine and
Yeah.
how sleep medicine. And I know, that's really important to me because I know for me, as I've gotten into this, I've seen how complex it is for a patient to get from point A to point B to ultimately wherever it is. And you've mentioned patients that by the time they get to you for a sleep problem or a neurologic sleep problem, they've been to 17 different providers
Yep.
over 5 to 10 years. And they're desperate and nobody can help them. And they've been misdiagnosed with everything under the sun. And like you said, I think for years and years and years, it was, they have high blood pressure and they have sleep apnea.
Yeah.
But I think now we're seeing it's like, oh no, they have high blood pressure because of their sleep disorder.
Sure.
So-
And we're seeing it broadened because, a lot of us have had this inappropriate focus just on sleep disorder breathing. But the reality is that literature is demonstrating that you can look at any sleep disorder and there is an association with adverse medical outcomes. And specifically, there's been a hyper focus on cardiovascular outcomes. Most recently, there's a lot of attention in narcolepsy and idiopathic hypersomnia, and them potentially being 2 times the risk of their age-matched peers for having adverse cardiovascular outcomes. If you look at the restless leg syndrome data, you look at the insomnia data, you look at circadian rhythm disorder data, we're seeing those same trends. And the reality is that when you create dysfunction in sleep, it's not as though you're just like, oh, this person is more tired or it's an inconvenience. The reality is you're disturbing something that is a homeostatic process, something your body must do. And so when you're creating this dysfunction, for us to think that there's not going to be other downstream effect is just ignorant, because the reality is the way the body works is purely based on feedback mechanisms. And so if you create dysfunction here, you're then going to create dysfunction downstream as well.
Yeah. And it's always been amazing to me how the symptoms present for some patients versus other patients,
Yes.
and how the symptoms don't necessarily relate to the severity of their issue.
100%. 100%.
But why is that?
Well, I think the reality is that part of the reason for it is because thinking that every patient presents exactly the same is just ignorant. There is not a disease process on earth that you can say the phenotype of how this patient presents looks like 1, 2, or 3. So, for instance, if I have a person who has a seizure disorder, there are no 2 patients who present looking exactly the same. If I have a patient who has autism, there are no 2 patients who present exactly the same. If I have a patient who has type 1 or type 2 diabetes, no 2 patients present exactly the same. The same as no 2 patients are going to have the same course in terms of the medication strategy or the behavioral strategies or anything else. The reality is that when we think that everyone is going to present exactly the same, we're completely neglecting the fact that there is genetic, epigenetic, cultural, and behavioral, and then also just access to care. And so depending on where you're seeing that person in their journey is going to also play into what is it that they look like at the time that you're discovering them.
Oh man, you used a hot button term there.
Yes, which one was that?
Access to care.
Yes, well, access to care is driving a lot of the problems that you're even describing of when you're saying that we describe a person of having obstructive sleep apnea, for instance, based on AHI. And the unfortunate truth is that we utilize that numerical value, so AHI being apnea hypopnea index, so a number of times an hour a person either stops breathing or has a 90% reduction in how they breathe, or a hypopnea where there's a reduction in breathing that's associated with either a desaturation of 30%, a desaturation of 3%, but unfortunately Medicare doesn't like to be as sensitive as the test can actually be, and so 4%, or an arousal associated with it.
Is it, and isn't that crazy? Like, can Medicare just change the rules when, like, is
Well,
the next thing that Medicare is going to say, no, it's 5%?
Yeah. Well,
Like-
the reality is what is frustrating is when I look at the Medicare standards and they're saying 4%, it's actually going against what the recommended standards are by the American Academy of Sleep Medicine, right?
Yeah.
So the American Academy of Sleep Medicine said, like, this is an option of 4%, but the standard should be 3%.
Yeah.
And so for those of you who are listening, what does that mean in like just functional normal practice? It means that you do a sleep study and you normally are 100%, but we see that you have a reduction in breathing. Like, we see that the flow of how you breathe, it should be like this nice sinusoidal like waveform, and then you're 100%, and now we drop you down to 97%. that counts as a breathing problem based on what the American Academy of Sleep Medicine says should be a breathing problem.
Yeah.
Medicare goes, no. We want to use these very old standards where we said 4%. And 4% means that breathing problem with the association with 97 doesn't count anymore. It has to be 96.
Yeah.
And so for many, it would be like, well, that doesn't seem like that big of a problem. 96%, 97%, isn't that normal oxygenation? No, it's not. The reality is that what you're creating is a dynamic of that the body's going, oh my God, there's something bad happening. Oh my God, there's something bad happening. Yep. And so it's not even necessarily so much that change in percentage as much as it is the downstream autonomic effects. So your autonomic nervous system, that is your fight or flight system or your rest and relaxation, it's going, I'm going to die. I'm going to die. Yep. I'm going to die. I'm going to die. And so when we decrease the sensitivity of the test, all that means is that we are missing the number of people who we can intervene on in an earlier state. What it's doing is it's biasing. Well, I mean, maybe that was a purposeful, maybe that was a purposeful Freudian slip. But it's biasing the algorithm to say, we're only going to care about those who are very, very severe. And the reality is that part of the reason that we bias in that way is because our data is saying like, well, it's the severe people we have to worry about. The data we're missing now is saying that if you're mild today, what do you look like tomorrow or in 1 year or in 5 years? And as a pediatrician or someone who focuses more so on pediatric sleep disorder breathing, I worry about that because when we don't actually intervene on those who have the mild OSA, we actually are creating a dynamic of much more severe problems down the road.
Oh, 100%. And I think, one of the cool things about pediatrics and looking at the development of children and the development of sleep apnea anatomically, we are seeing so much more now because of what's happening during development of children.
Yes.
So, we look at these studies on malocclusion and, books like Jaws from Sandra Kahn and, what are kids eating and how everything's processed and baby food and they don't chew, they don't gnaw, they don't develop their palates. Maybe breastfeeding's not happening as long or as much. There's more bottle feeding. And so the palates don't develop, the jaws don't develop. You end up with this retrognathia, and then you end up from a developmental standpoint with an increased risk for airway issues over time.
And so essentially what you're describing is that many of the things that we're doing, so we sometimes take this for granted of that the focus of just eating, we think about it as a source of nutrition, but the reality is how we eat, what we eat actually changes our face structure as 100%. Well as our oral structure. And so with breastfeeding, we always talk about breast is best and not to stigmatize for women who have difficulty breastfeeding. I as a mom had to supplement with formula because I just was unable to produce enough. But the reality is that the breast is creating an oral dynamic that is going to enhance the likelihood of the way my palate is made is that it's going to be more well arched versus a higher arch where when I'm just putting a nipple, which is kind of like a finger, it's going to reinforce there to be a higher arch. When we're looking at those higher arches, we're now creating a smaller airway, which is going to be more susceptible to collapse. And so I think that's an important dynamic for people to understand because those things also play into how our dentition is made, our likelihood for bruxing or grinding our teeth, and it creates abnormal dynamics that are not surgically modifiable. Like I can't just do a surgery and say, your airway now is going to have better musculature, right? Your muscle tone is going to improve. The surgeries can change the dynamic of how my arch is, which if done early enough can change those muscle tones.
Correct.
But it's really important to have that identification early on.
But then you're talking about a really big surgery too. You're talking about a very invasive surgery. You're talking about the risks that come along with surgery. And granted, I'm a lot more, when I first started in dentistry, I was very hesitant with kids. And when I say kids, I'm talking maybe teenagers going through braces who had this overjet, overbite retrognathia, and
which is pushing jaw back,
pushing jaw back, which
now I'm pushing my jaw back, I'm pushing my tongue back, and so now I'm blocking my airway.
But when you know that the correct fix for that from a occlusion standpoint is a jaw surgery to bring the jaw forward and all that kind of stuff, I was very hesitant to recommend that for patients. Just because I know, one, it's expensive, two, it's invasive, three, it's a process. There's pain, there's swelling, there's infection, there's all those things.
100%.
I mean, wired shut, back in the day and all that kind of stuff. And now I'm a lot now knowing what I know about airway and going back to what you don't know. And this maybe is where we can get back to the change in medicine. But knowing what I know now about airway issues, I am so much more likely with that 13-year-old to say, you know what? Yeah, you could try to do it without surgery and do the best you can, but you're still going to have an airway issue.
Yep.
I am so much more likely to push those patients towards orthodontic surgery to kind of
Yeah.
help them at least get in a position where they can, you know, have success with their airway later on. And I just don't know what the solution though is.
Well, I think part of the solution is actually making an ecosystem for patients to be able to navigate healthcare in a way that is unified. So I think there are several layers of the obstacle. So number one, when you look at medicine in general, we are so super subspecialized. So it's not even enough for me to be a neurologist, but then I'm a sleep doctor. And then you look at my group, it's like, I only focus on seizures. I only focus on muscles, or I only focus on like your big toe, right? And so when you look at medicine, how many people are there that look at the mouth? You have ear, nose, throat doctors, you have dentists, you have orthodontists, you have oral maxillary, facial, like who is in charge of the mouth? Like, and so when you're talking about airways, like what is the airway? Does the airway start at the nose? Does it start at the mouth? Does it start at the trachea? Does it start at the lung? Like, and so even if you're looking at that, how many different specialists did I just name? Right.
Yeah.
And so when you don't have anyone who's going to actually be like, I am the directionality of like, I'm owning this. Right. You then end up with this very fragmented care of like, I give you what is my best, but my best is not totality. Right. And so patients who show up for me as a neurologist, who's a sleep medicine doctor, who has sleep disorder breathing, for instance, I'm looking at this. I'm looking that you have alar collapse. So that means when I suck in my nose, like when I breathe in through my nose, the nasal passages like collapse, like they actually kind of suck in. I then look in your mouth and I say, oh, wow, you have a high arch palate. Like your airway, your mouth is kind of almost making like a little teepee inside. I'm looking at your throat and I'm going, wow, you have tonsils, or like your uvula, that punching bag is like really low down. Like I'm looking at all these things and I'm going, who do I send you to fix all these problems? And then very frequently I do ask, I see you grind your teeth. What has your dentist said about that? Nothing. I didn't know I was grinding my teeth. Well, you have 32 cavities. Every single tooth in your mouth has a cavity, and it's from so much wear. Like what? Well, they told me I grind, but they said because I'm a kid, there's nothing I can do. Right. Yeah. And so there's all of these dynamics where we kind of are like passing the buck, and then we put it back on the patient to say, you're responsible for your healthcare. Why haven't you done what you're supposed to? And the reality is that we're all too malinformed.
Told them what they're supposed to do.
We're
no one knows.
too malinformed, right? Yeah. And so I think really that is part of it, right? Is there's the medical side. But then you look at the next layer, which is how do we afford it? So most people have insurance. They have healthcare insurance, and they may or may not have dental insurance. The two don't talk to one another, right? And so the things that I'm going, you need to talk to your orthodontist about being able to expand, like don't do braces, do a palate expander first. Like, and so they're going, I can't do that. That costs too much money. And so it puts a predicament of people going, well, I'm just not going to make that recommendation anymore. I'm not. And so I really think part of the solution is figuring out that conversation.
Yeah, I see that a lot with physicians where they are hesitant to refer. It's interesting. And you may be able to tell me on this. Do you know, like, what's a common procedure that you do in your practice?
So for me in neurology, our procedures are not based on sleep. Like we do like spinal taps and we do like EMGs and EEGs and things like that.
Okay. So how much do you charge for a spinal tap?
So we don't charge, like, so for me, it's like, I'm not private practice. I'm part of an academic healthcare system. So I just like.
Yeah. Well, how much do they charge if a patient?
I have no idea.
You have no idea.
Yeah. No idea.
And a lot of physicians are like that. I go talk to physicians and they go, and I'll
because the insurance covers it.
Well, exactly. So I'll talk to an ENT and they do tonsils, they do allergy testing, they do sinuplasty, they do this, they do that. They've got the list of procedures that they do. I talk to dermatologists, they do this and this and this and this. I talk to ophthalmologists, they do this, this and this. They do the laser, cataracts, da 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 da. And I say, how much do you charge for that? And none of them know.
Yeah.
None of them know.
Well, we also don't get taught in the business of medicine, so that's part of the problem.
Well, and that's why I want to talk about that. But then what they do is they ask, well, how much do you charge for this oral appliance?
Yeah.
And so when we have the conversation around, well, the oral appliance costs money, like they are so hesitant to refer because let me see how I phrase this. Is it because they don't want the dentist to make money, or is it because they don't want the patients coming back complaining?
I would say that our big fear is our patients having bills that are bigger than what the problem may be perceived, or that they just can't afford it. So I work in a very, very large healthcare system, and we have one of the probably most socioeconomically challenged populations. So
Yeah.
it is a population they are very hard workers, but the income is not going to substantiate their ability to be able to pay for things that aren't covered by insurance.
Yeah.
And so that very frequently is a part of the equation. So like in medical school and even in residency and everything else, there now is this systems-based practice that we're always thinking about. And it's like, how much is the cost to the insurance? How much is the cost to the patient? Like, is this the best avenue? And so I think when we're looking at things that are going to be out-of-pocket expenses, we already are calculating that ahead of like, one, it's a cost we don't want to pass on to the patient. But number two, that we also are worried about how is this going to impact our likelihood of proceeding with our recommendation? Are they going to follow up with us? Are they going to, because they're going to just say like, this doctor doesn't care. They think I can afford XYZ amount. Like I'm not going to do it, and I'm not going to follow up because I'm too embarrassed to tell them I didn't do what they asked me to do.
Yeah. Well, and I think that's where sleep patients fall out like this. So let's talk about the business of sleep.
Yeah.
And get into, there's the process of getting a patient into the system to get diagnosed. They have a sleep disorder. They have insomnia. They have whatever they have. They first have to find a doctor that's recognizing the issue.
100%.
Then they have to get referred to somebody that will confirm that there's an issue and test for that issue.
Yes.
Then there's got to be some figuring of what's the therapy. Is there a medication? Is this cognitive behavioral therapy? Is there an appliance or a CPAP or whatever you need? But so there's like 1, 2, 3, 4 stopping points. Yeah. And then there's
probably even more
probably more. And then there's the follow-up process of which doctor, that doctor sent him to that doctor, that doctor sent him to that doctor, that doctor sent him to that pharmacy or that DME. And then like the follow-up and whether or not those patients are following through with therapy or too embarrassed to come back. Because I know a lot of patients that like are afraid to go back to their, what I see is patients that are afraid to go back to their doctor because they're not wearing their CPAP and they're afraid they're going to get lectured for not wearing their CPAP or something like that, right?
Yeah, yeah.
And then each one of those people has some kind of financial, whether it's the hospital system or the doctor themselves or the CPAP company or the pharmaceutical company that's doing the drugs, there's some sort of business and financial decision there.
Yeah. Yeah. So what's interesting is that I first want to acknowledge the taboo language of saying the business of medicine, right?
Yeah.
And so the reason I say it's a taboo language is because many people who go into the medical practice, they do it for what they think is like, I'm doing this to be selfless. If I could just
shellfish?
speak today, shellfish. Like I want to be a lobster, and so therefore no. So the reality is that many people feel as though that it's negative to talk about business of medicine, but the reality is business of medicine just means what is the efficiencies of being able to help in navigating the appropriate identification, the appropriate diagnosis, the appropriate intervention, and the appropriate follow-up. That's really what we're talking about when we're talking about the business of medicine is the efficiencies surrounding that. And so when you talk about the efficiencies surrounding that, you then are talking about cost management. And that cost management includes the financials for the patient, the financials for the healthcare system, and the financials for the insurance. But when you say business of medicine, many people go, I knew it. I knew that dentist only wanted to make money. I knew that doctor only wanted to pay for their Porsche's loan or whatever it might be. But the reality is that these are really true, important frameworks to consider, and really a starting place of saying, where can we fix things, right?
Yeah.
Where can we actually better improve on the identification? Where can we better improve on the rate of diagnosis and the appropriate treatment, and not create a punitive system where patients feel, like you stated, fearful? And so one of my big mantras is always telling patients, listen, you know what I'm an expert in? I'm an expert in the diagnosis, the treatment, the disease processes. You know what you're expert in? You. I have no idea about you. I have no idea what your day-to-day looks like. I have no idea what the things that bother you, what keep you awake at night or anything else. And so the reality is what my goal is to empower you to be active in your personal journey so that I can flex and exercise my strengths on my expertise on the disease state, the management options, the kind of expectations so that you have a personalized journey. Where we're at now in medicine is really a lot of artificial conversations around things that we pretend matter because we elevate them to the point of saying that these are buzzwords that matter. But the challenge is that we purely are really highlighting buzzwords and not actually actions that align with it.
What's an example of some of those?
So for instance, some of the examples are saying value-based outcomes. We want improved value-based outcomes. We want to consider diversity, equity, and inclusion. We want to be able to improve access. But the reality is that what that means is we want to have you see more patients in less time to get them to a treatment that may or may not be the best. And we're going to apply preconceived notions of what we believe different ethnic groups, different people from socioeconomic backgrounds have barriers on, but we actually don't want to think about what does that journey look like and how do we engage those individuals to be able to achieve the needs they have at the time they need them and have this false preconceived notion that artificial intelligence somehow is going to figure this all out for us.
Well, I think it's interesting. And I think the other factor behind the business of medicine or the business of sleep medicine is a poor understanding of just people in general on exactly what it takes to run a business.
Yes.
And I think that when you're in, and you understand this because you have your consulting and speaking and the things that you do and understand there's travel costs, there's hotel costs, there's, lectures and whatever else that you have to pay for in order to make that happen. But a lot of physicians I talk to are, they're not the ones paying the bills. They're seeing the patients and it's a great thing for them because they get to show up and just see their patients and take care of their patients, which is really what they want to do. But they may not have any idea how much it costs to keep the lights on in the building or how much it costs to employ the people answering the phones and things like that. And I think that's where a lot of my dentist colleagues, at least the ones who haven't sold out yet to corporate dentistry, are they're dealing with the cost of labor, the cost of supplies, the cost of equipment, the cost of, and then you throw on top of that city ordinances, taxes, property taxes, all of these things. And so when somebody comes in and says, "Oh, I can't believe it costs that much." Yeah. I mean, that's like going to Whole Foods and saying, "I can't believe it costs that much for a bell pepper," but we don't know where the bell pepper was grown, what they used to grow it, how much they pay the people to grow it, how much they pay the people to get it, to transport it there, and all that kind of stuff. And so there's just this understanding or misunderstanding of what it actually costs to run a business.
Yeah. And I think one of the challenges is that irrespective of what all that represents, the cost is always passed down to the patient. And so the patient then is constantly having to make the choices as to what is it that I'm actually going to receive care on, and then they prioritize it. And the way that we've currently structured it is that many times patients in general are going, dentistry is one of my last concerns, right? And so one of the things that is so interesting in medicine in general is that we generally talk about dental care as being something that is not a part of medical practice, right?
Yeah.
And so when we look at periodontal disease, for instance, and we recognize that it has downstream effects on every organ system and increases your likelihood for adverse heart issues, adverse cognitive issues, adverse microbiome and GI issues, we really are doing ourselves a disservice. And so I think that a major step that we need to take is figuring out how do we actually create more of a symbiosis between what dental practice is doing and what medicine practice is doing. And I think that the reality is that reframing it to also just consider what is it that patients are looking for? And so I don't think that I've ever met a patient who's looking for only a fast fix, right? They're not looking for just a Band-Aid. They're looking for, how do I actually transform my life so that I can live my healthiest life, my longest life, my most enjoyable life.
Mm-hmm.
And those three things shouldn't be mutually exclusive. I shouldn't have to make a decision as to I'm going to take one over the other. But unfortunately, the way that we're structured, that is the decisions that patients are making every single day.
Yeah, and my fear is that medical insurance is not going to ever want to take up the cost of dentistry.
Yeah.
Like, because that's the business of insurance.
Yeah.
We talk about the business of medicine. Well, that's the business of insurance, and they're doing what they can to make
Sure.
their money and keep the money in their pockets as well. And so that's where the system gets kind of wonky. And I think sometimes people end up feeling a little hopeless and just kind of like, I think a lot of medical providers will get into that boat. But what I'm hearing you say is you want to drive change
Yeah.
in this model, in this
Yes.
business. And
Yes.
what does that look like? What is it?
So for me, it's really creating ecosystems, right? And so I think when I look at the practice of medicine, and this is for no matter what you're talking about, when you go to see a person for your care, they generally are like, I'm focused on the reason that you're here and what I need to do for you right now. And we're not frequently stepping back and going, so you're here because you have high blood pressure, or you're here because you have a seizure disorder, or you're here because you have diabetes. What are the other factors that frequently come along with that? And so that comes with not only thinking about your other medical issues that may come along with it, but also psychological, developmental, social, financial. How does this impact, for me, my kids being able to attend school? How does it impact the parent being able to attend work?
Yep.
How does it impact the ability for you to get medications and take medications? And so there really is this need to step back and go, what is it that we're treating? If we really want to talk about this buzzword of value-based outcomes, which really just means I cost less for my insurance to take care of, and that reportedly is equal to I have better healthcare experience, then we really need to say, does it stop at just the medical experience, or does it also impact the socioeconomic disability that's associated with many of these conditions, as well as being able to have all of these other areas addressed?
Yeah.
So I think that when we're looking at the kind of the evolution that we need to have in medicine, I think there's so many things that need to just completely be transformed. I have yet to find anywhere else in the world who's cured this problem. And so there's definitely different ways of delivery in the world of healthcare, but I haven't yet found any that are actually the optimal. There's definitely other countries who've done a lot better job of being able to do preventative medicine, right?
Yeah.
They've done a really good job of making sure that people get all of the right preventative care. Interventional care is still something that I see internationally being worked on as a measure of being able to get to those interventions that are needed in a timely fashion. But I think at the end of the day, the piece that is going to make the biggest difference is really empowering individuals to understand when they need care, what care looks like, and what does great look like, right? What does your optimal outcome look like?
Yeah.
And that can't be some preconceived, templated look.
Well, and I love what you said there, because I think that's when you talk about wellness, prevention, and wellness is the total opposite of the healthcare system that we kind of live in right now, which is more of not healthcare, but as much as sick care.
Yes.
We're focusing on taking care of people once they're sick, as
Yes.
opposed to preventing them from getting sick.
Yeah.
And so I think that focus of getting people on board. What do you think in sleep is it going to take to get people all noticing and understanding? Is this something where I see more and more screening for sleep apnea, which I think is a good thing. I think to have cardiologists and endocrinologists and internal medicine docs all screening.
It's a great thing for them to screen using tools that actually screen for the right patients, right?
Yeah.
So when you're talking about screening, most of them are using bias surveys that are really predilected for
Go back to stop banging.
Yeah, exactly. For men who
Fat
are
old men.
overweight. Exactly. And so aren't really taking in the whole phenotype. The other piece is that it's also not considering the fact that the International Classification of Sleep Disorders, Edition 3, recognizes over 70 different sleep disorders.
Yeah.
And so when you have a person who has one sleep disorder, the likelihood of them having 2 to 3 sleep disorders exponentially rises. And so even if you wanted to just take OSA as an example, the likelihood of them also having insomnia, circadian rhythm disorder, restless leg syndrome, or periodic movement, that increases. Excessive daytime sleepiness, that increases. In fact, one of the close collaborators that I have at UPenn, Alan Pack, has published on this, on saying that we should be considering these phenotypes beyond just an AHI. In fact, some of the publications that he's done and replicated worldwide is that the excessive daytime sleepiness phenotype is the one that we need to be most concerned with. He's also given breakdowns of that. Maybe it's those who have a specific arousal index, or those who have a periodic limb movement. And the reality is that all that they're highlighting is what all of us who in sleep medicine already observe, which is if you see one patient with sleep apnea, you've seen one patient with sleep apnea. If you've seen one patient with insomnia, you've seen one patient with insomnia. If you've seen one patient with narcolepsy, you've seen one patient with narcolepsy. The reality, it's not cookie cutter. There's nothing in medicine that's cookie cutter. And so what do we need to do in medicine that was going to actually make a meaningful difference is stop talking about sleep medicine to other people who do sleep medicine. We already know. We drank the Kool-Aid, right? The reality is what we need to do is exactly what we're doing here with this podcast, is talking to the general public, talking to other healthcare providers, talking to people in a capacity that makes a difference to them, understanding that sleep isn't a nicety, that it's like, great, I slept my 8 hours and I'm doing so great. And also moving away from this idea that everyone is 8 hours. There is a neurodevelopmental change in regards to how many hours of sleep you need per night. The younger you are, the more sleep you need. The older you are, the less that you may need. It doesn't mean that still getting 5 to 6 hours is okay.
Yeah.
The other piece is not talking about sleep outcomes in the capacity of sleep outcomes alone. No one cares. No one cares if I move you from 7 hours to 8 hours. No one cares that I consolidated your sleep. No one cares that your sleepiness is improved. What they care about is that I'm a cardiologist. I didn't give you another heart attack. I didn't put you back into atrial fibrillation. I'm a neurologist. I don't care that I care that you didn't have another stroke. I care that I treat your Parkinson's and your REM behavior disorder didn't cause you to have a brain bleed because you ran headfirst into a radiator.
Yep.
Those are the things I care about. You have type 2 diabetes, your hemoglobin A1C is actually under 6% because the fact that your cortisol isn't out of control and your insulin resistance has actually improved because you're getting the right number of hours of sleep.
Because you're sleeping the right number of hours, the right
Exactly.
quality. Yeah.
Exactly. And so this is the problem that we're facing. And that for most of the people who are listening to this, all of those things I just said, they also don't care about because maybe it's not applicable to them. What they care about is the fact that they want to have sex. My penis is working correctly.
Yeah.
They want to go to work and they want to get a promotion. I'm able to actually be psychologically, mentally present and primed to be able to outcompete the person next to me. I'm an athlete. I'm able to actually get and be that MVP. These are things that matter to people. And the reality is that your secret weapon at the end of the day shouldn't be so secret. It's your sleep.
It's sleep.
Getting the right quality, duration, timing of sleep, that's what's going to give you your best view.
Yeah, I couldn't agree more. I love what you're saying.
Speechless,
And
I know.
No, yeah, I honestly like. I love what you're saying because this is exact. And again, we drink the Kool-Aid. We know this. We're in sleep. We
the sugar-free
understand this.
Kool-Aid that really isn't sugar-free because
that-
then we're going to have cardiovascular disease and
yes.
microbiome, but our teeth will be okay.
But you have to like. But you have to, and I wonder too if there's like a generational component to this. Like
Yeah.
I feel, I don't want to be an ageist, but is there a generational component to where some of the older regime is kind of set in their ways and versus maybe coming up, there's more open-mindedness to some of this stuff.
Yeah, I feel like we're stuck in both directions because the younger generation, they're going, I don't want to miss out on anything. And so looking at sleep is still curtailing something getting in my way of missing out, of me scrolling another page. And then I think the older generation, they're facing two things. Number one, they're used to a regimen of like, this is my work schedule, so I did all my life, blah, blah, blah. But then they're also, as we get older, our sleep does have the tendency to become more fragmented. Our duration becomes harder to attain. We end up with more of an advanced sleep schedule, going to bed very early, waking up very early. And so I think all of those things end up being significant dynamics that are limiting. And so if we're able to engage all populations into understanding what does your amazing look like? Like, tell me what would be amazing day to day. I guarantee you we'd be able to infiltrate into that. This is how sleep plays a role in that.
Yeah. Yeah. And I think the more that we can get all the providers working together, it's one of the most frustrating things that I deal with is not being a real doctor sometimes when I'm looking at airway issues and I refer a pediatric patient who's got the palate, who's got the airway, who needs the tonsils out, who needs the breathing fixed. And the ENT is like, oh, that dentist doesn't know what he's talking about. You're fine. You'll grow out of it.
Yeah.
You know, this, and so then that just makes it hard because then you lose trust with the patients and the patient's parents in terms of why are you sending me there? They said nothing's wrong and da. So that when the community is not on the same page, it creates mistrust in the system with patients. And so I just don't, I think that's where we're headed. And I think that fixing that is going to be, go a long way towards the issues that we're facing.
And I think one of our hopes as a part of Sleeping Around a Podcast is recognizing that transformative change takes transformative attempts at intervening to large groups, right? And so medicine, we're stuck in our ways and we can't get out of our own way. But you know what does change how I practice medicine or how my team practice medicine or how most healthcare systems practice medicine is patients demanding better outcomes, better care, and being knowledgeable, right? And so as opposed to most physicians who will quote things like, don't mistake your Google search with my doctoral degree, I completely advocate, encourage, and celebrate when my patients are saying, this is the information I'm looking at, and this is the information that is making me ask you these questions that impact me as the person you're taking care of.
Well, those patients are involved. Those patients are the patients you want to work with because they're taking ownership of their healthcare. They're trying to figure it out and they're bringing that to you. They're telling you that they have a problem and they're asking for your help with that problem. They're
exactly.
Not, so they're not telling you that they know better than you, but I get what you say.
Yeah. And this is our call to action for our SAB viewership is that you guys are our sleep friends. We're here to be able to answer the questions that you guys have. But the reality is that we're hoping is that you take the information that you're gathering here and that you ask us about and you utilize it to change your own personal journey. And whether it's your personal journey or it's your kids or your husband or your wife or your friends or whoever it might be, utilize it to the effect of change so that we in medicine do better for you.
And I on dovetail on that is make sure you subscribe to the channel, make sure you watch, put the notifications on and share it with your friends. But if you want to, in the comments, if you're a patient who's been through this, or if you're somebody who's dealt with sleep problems and you've got questions about it, put those questions in there so that we can address them. And I'd love to see, I know we have a lot of healthcare providers that listen and watch. I'd love to see your thoughts and comments on how we continue to improve, change and improve the healthcare system that we're in and the process that we're putting patients through in terms of getting the best outcomes.
Yeah, 100%.
Yeah.
And I think that the reality is we've covered a lot of really good ground today. We definitely tried to figure out and problem solve for how do we unify dental sleep, medical sleep. And the reality is at the end of the day, we should just be calling it sleep, right?
Sleep.
And that's why we're Sleeping Around a Podcast. We're trying to figure out how do we get as many involved and make more sleep friends as we go along.
Absolutely. Absolutely. And this has been great. And I'm so excited to be doing this with you and to do more with you and to bring to our viewers all the education and information that we're bringing.
And we didn't even need Matthew.
And we don't even really
I think we could just get rid of him.
We
probably just get rid of him. We just have to keep the
We'll
monkey.
keep Hot Monkey Love here.
Yes. Okay.
But no Matthew.
Yeah, I think that's good.
Okay.
All right, I got it. Yeah.
All right. Thanks for sleeping around with Dr. Ann and Dr. Brandon.
Just keep it between sleep friends.